So I've been doing this anterolateral pre-psoas approach, also known as OLLI, for quite some time. And I know Charles' favorite procedure is MIS the Tilly procedures. If he has to just choose one procedure that he wants to do for the rest of his life, if I have to choose one, that's got to be OLLI procedure. The advantages are many, and it's obvious. And you get to decompress and fuse in front of the lumbar plexus and the psoas muscles. So there's a low risk of neurological injury. And you get to take a full advantage of ligamentotaxis, putting a much larger implant than you can with any other approaches. You get better decompression and a deformity correction. Because you are working right in front of the lumbar plexus, you don't need to do any IOM, so it is much more efficient. Operation is performed over the lower part of the ilium, so you don't have to break the bed to access L4-5 for the person that surgeons who's doing early procedures. And because of that, you put a less stress in psoas and lumbar plexus, and also L5-S1 can be accessed. However, the biggest advantage of this procedure, I think, is you get to visualize everything before you make any kind of commitment, because you're actually doing dissection. But also the biggest disadvantage of this procedure is you have to do the dissection, like a general surgeon and vascular surgeons. And these are one of the procedures that you're doing it, and then you start regretting, God, I wish I paid more attention during my general surgery rotation, vascular surgery rotation. But, we're going to be neurosurgeon and spine surgeon. We didn't give a damn, Besides, they send us to do the scut work, so actually never really get to do any anatomy dissection during this rotation. So we are very unfamiliar with this dissection. We kind of put ourselves in unfamiliar territory. This two-incision tunneling access technique, and acronym was a TTAT, it's aimed to reduce the anxiety being in the wrong place. So if you're one of those persons like Charles who's never going to do any OLLI procedures, he might say, I'm not going to do it, so I don't need to know about this. Or if you're in academic centers, you may say, I have really good vascular surgeons, and he's at my disposal. Then, so I don't need to learn this. But if you're in private practice, and you like to incorporate OLLI into your practice, and if you happen to find yourself in the wrong place, and the following technique can save your ass. It didn't mine. Okay, so this is the same naked lady that you saw multiple times during this talk. I'm gonna use a different model next time. So this is where you make incision for OLLI L2 to 5, and it's about 6 centimeters anterior from the midline of the disc for OLLI L2 to 5. You can make either one vertical incision, and you can make one longitudinal transverse incision. My preference is making a transverse incision. It heals much nicer, and it's cosmetically more pleasing. For L5-S1, you make incision approximately 4 centimeters anterior to a iliac crest. For 2 to 5, you make incision, and you go through external oblique fascia, external oblique muscle, internal oblique muscles, and a transversalis muscle. After that, you see this very flimsy transversalis fascia. You got to go through that, and it's going to take you to retroperitoneal fat pad. After that, you put your finger in there, you palpate psoas muscles, palpate transverse processes, and then you palpate peritoneum, and you mobilize immediately, and you put a retractor to anterior 1/3 of the disc, like this. So this is the view that you're going to get. So to the front, you get this ureter and peritoneum, and to the back, you have a psoas muscle and a lumbar plexus. It's not a very comforting sight, is it? And besides, if you have to operate on somebody like this, who's got a very tight peritoneum and a very tight retroperitoneum, you try to make incision, and the next thing you know is you're going to find all this stuff coming at you like a nightmare. That's the time then you cuss and you go, I'm never going to do this procedure ever again. If you ever run into this kind of situation, don't give up. Instead, do not hesitate to make incision posterior to this OLLI incision that you made. That incision location is got to be very similar to your typical L-lib incision. And you put your finger in there, you palpate TP. And then you make a tunnel with your finger anteriorly until your finger emerges through this OLLI incision. Then you know you're in retroperitoneum. Then you can park your retractor, and you can go on with OLLI procedure. OLLI L5-S1, after you make incision, you got to go through external, internal oblique muscle sometimes. Most of the time is aponeurosis. And then you find retroperitoneal fat pad. You put your finger in there. you dissect into the inner table of the ilium, and you're going to palpate psoas muscle, and you're going to palpate this very pulsating common iliac artery. After that, you palpate peritoneum, and you're going to mobilize it medially, right? And you put the retractor here. This is a retractor that I use. Now, when you do this procedure, and ideally you want to see the retroperitoneal fat pad, but sometimes it can be confusing. And if you go through peritoneum, which is quite easy to do, then you're going to see all these slithering guts coming at you, right? So for first few times, after you've done only L2 to 5, for many cases, I recommend you do about maybe 20 cases of the L2 to 5 before you start doing an OLIVE L5S1, okay? So I recommend you approach this incision as if you're gonna do OLIVE L2 to 5, okay? So you made OLIVE L2 to 5 access, and your fingers are in retroperitoneum. You tunnel your fingers to the anteriorly where you wanna do OLIVE L5S1. And you're gonna dissect where your fingers are tenting, layer by layer, until you see this fingertip. Do you see that? Emerging to the skin. It doesn't have to be a fingertip. It could be assistants, your PAs, and whatever. And then once you've done it, you can put your fingers in there, and you can meet in the middle of the patient's retroperitoneum. And then you can park your disc, do the annulotomy, and perform OLIVE L5S1. So this two-incision tunneling access technique, TTAT, is a surgical technique intended to safely guide surgeons to retroperitoneum. You use the same principle for 2 to 5 and L5S1 access. You go from the known to the unknown. This could be a nice training wheel for the novice surgeon who like to incorporate OLIVE in their practice, and it could be a fallback for experienced surgeons sometimes when they find in the unusual anatomy and find themselves in trouble. Thank you.